You know that feeling on a plane when your ears feel like they're just going to pop? Or maybe if you've dived down deep swimming, that weird squeeze?
Yeah, that pressure change discomfort. We've probably all been there.
Exactly. Well, today we're going quite a bit deeper. We're looking at a related issue, but one that crops up in a very specific medical setting: hyperbaric oxygen therapy.
It's fascinating, isn't it, how that familiar feeling, that pressure imbalance, becomes, well, a critical factor inside these treatment chambers. It demands really specific ways to manage it, keep patients comfortable.
Right. So we're diving into barititis. It's often just called ear squeeze. And surprisingly, it's the #1 issue people run into during hyperbaric oxygen therapy, HBOT.
Hmm.
Think about it. Patients are inside this sealed chamber, and the pressure is being deliberately increased. So we want to unpack why this ear squeeze happens, what it feels like, what signs to look for.
And how doctors handle it,
Yeah.
including a procedure called Myringotomy, which we'll definitely get into.
Our sources for this deep dive, we're leaning heavily on chapters from hyperbaric medicine practice, really solid clinical background there.
And we're also focusing on a specific chapter, just on Myringotomy. It gives a very detailed look at that particular intervention because, in these chambers, the pressure goes up, sometimes like being quite a few feet underwater.
So that pressure difference is what drives this whole need for equalization in the body's air spaces, like the ears.
Exactly.
Okay, so our mission today: understand how the medical teams keep patients safe and, frankly, comfortable inside that pressurized environment. It's all about managing that pressure.
And why should you, listening in, care? Well,
Mhm.
even if you never go near a hyperbaric chamber, understanding how your body reacts to pressure changes. It's fascinating physiology.
Yeah, and it shows some really smart medical problem solving.
Plus, like you said, some of the tips for clearing your ears might actually come in handy next time you fly.
Definitely could. Okay, let's get into this ear squeeze, barititis. In the context of HBOT, what are we actually talking about?
So, simply put, barititis in this setting is when a patient just can't equalize the pressure. The pressure inside their middle ear can't match the rising pressure inside the chamber during that compression phase.
Okay. Is it always the ears?
Mostly, yeah. Ear
Okay.
squeeze is the most common. But you can sometimes see similar problems in the sinuses too. That's called burosinusitis. Less frequent, but it happens.
Right. So the pressure's building up outside, but the inside isn't catching up. What's physically stopping it? Why can't it equalize?
It really comes down to the Eustachian tube. That's the only natural pathway connecting the middle ear to the outside air, basically the back of your throat.
And it's usually closed, right?
Normally closed, yes. It's meant to pop open briefly when we swallow or yawn, do certain things. But during pressurization in the chamber, if that tube doesn't open properly, you start to get a relative vacuum forming inside the middle ear.
A vacuum inside your ear. That sounds really uncomfortable.
It can be, yeah.
How would you know? What are the symptoms, the signs?
It varies. It can be anything from just mild discomfort to pretty significant pain. Usually, the main thing is a deep ache. It could be one ear or both.
And if a doctor looks inside?
Well, with an otoscope, they might see the eardrum looks like it's pulled inward. That's called retraction. Or the blood vessels on the eardrum might look swollen or more prominent. We call that hypervascularity.
Okay.
In more severe cases, you can actually get blood collecting behind the eardrum that's hemotympanum.
Yeah.
Or the eardrum could even rupture.
Rupture. Wow.
Yeah, sometimes with bleeding from the ear canal itself. That's a hemorrhagic otorrhea.
That definitely paints a picture of serious discomfort. Does how fast they increase the pressure matter?
Oh, absolutely. Critically important. If the pressure goes up nice and slowly, gradually, it gives the Eustachian tube more time, more opportunity to open and equalize things.
But if they rush it?
If the compression is too rapid, it's much more likely the tube just gets, overwhelmed. It can't adjust fast enough. And that's when you run into these problems.
Okay, so slow and steady wins the race here. We keep mentioning the Eustachian tube. You said it equalizes pressure. Does it do anything else important in this context?
Well, the main job we're focused on here is pressure.
Right.
But it also protects the middle ear, helps stop secretions from your throat getting up in there.
Right.
But getting back to the pressure, letting air out of the middle ear is somewhat passive. The tube structure allows that. But letting air in during compression, that requires active muscle work.
Active? What muscles?
Specifically, muscles in your palate, your throat. The tensor veli palatini is the key one. Contracting that muscle is what actually pulls the soft, collapsible part of the Eustachian tube open.
Okay, so it's not just a simple pipe. Your body has to actively open it. What kind of things mess that up? What stops the tube working properly?
Quite a few things, unfortunately. Any swelling or, extra mucus in the lining of the tube itself, that could be from an infection like a cold or allergies,
Mm-hmm.
maybe irritation from smoke or even just really dry air. Also, if the normal cleaning mechanism of the tube, the sort of tiny hairs clearing mucus, isn't working well, or in kids, sometimes enlarged adenoids can physically block the opening.
Ah.
And then there are conditions that affect the muscles themselves, like a cleft palate, or simply the tube can get blocked by really thick mucus.
Lots of potential roadblocks then. You also mentioned something about the tube blocking. What's that? Sounds bad.
It is pretty frustrating when it happens. Locking occurs when that pressure difference, the pressure outside versus inside the ear, gets too big.
All right.
The threshold is around 125 Torr, which is roughly one whole atmosphere pressure change.
Wow.
Once you hit or go past that point, the outside pressure effectively clamps the tube shut. It's physically pressed closed.
Yeah.
And at that point, swallowing, yawning, trying to pop your ears,
Yeah.
it's not going to work.
It's just stuck shut.
Pretty much. Non-surgical methods won't open it then.
So what do you do if that happens? You can't just leave someone like that.
No, absolutely not. The immediate step is you have to carefully, slowly bring the chamber pressure back down to normal, back to sea level.
If you compress.
Right. Once the pressure is equalized, if the treatment still needs to proceed, you have to restart the compression phase. But this time, very slowly, really give the tube a chance to keep up.
Okay, so slow is the backup plan. But let's say the tube hasn't fully locked, someone's just having trouble clearing. What non-surgical things can you try first?
Well, there's several maneuvers. One people know is the Valsalva, but we need to be specific. The standard Valsalva, like straining, that doesn't really open the tube.
Right.
The modified Valsalva, pinching your nose, closing your mouth, and gently trying to blow air out, keeping your throat open, that's the one aimed at pushing air into the middle ear.
But I feel like I've heard warnings about that one.
You have, and for good reason. While it can work sometimes, it's generally not the first choice, especially in HBOT. The big worry is it can significantly spike your intracranial pressure, the pressure inside your skull.
That doesn't sound good.
No. And in rare cases, it might even push cerebrospinal fluid back towards the inner ear. That's a serious potential complication we really want to avoid.
Definitely. Okay, so if Valsalva is risky, what's a safer bet?
Much safer, and often just as effective, is the Toynbee maneuver.
Toynbee. How does it work?
Simple. Pinch your nostrils closed, and then just swallow. When you swallow, those palate muscles naturally pull the Eustachian tube open. And crucially, it does this without jacking up intracranial pressure.
Pinch and swallow. Got it. What about medicines, like decongestants people use for colds? Do they help here?
They can, sometimes, specifically topical ones, nasal sprays, things with oxymetazoline, xylometazoline, phenylephrine.
How do they help?
Sprayed into the nose, they can shrink the swelling, the congestion, right around the opening of the Eustachian tube in the back of the throat. That can make it easier for air to get through.
So targeted relief. What about pills, oral decongestants?
Generally not the best idea for this specific problem. They affect blood vessels all over your body, not just where you need it near the tube. To get enough effect near the Eustachian tube with a pill, you'd likely need a dose so high it could cause other issues, like heart palpitations or high blood pressure. The risks often outweigh the benefits there.
Makes sense. Stick to the spray if you use anything. Now, what about those earplugs, the ones marketed for flying? Do they have any place here?
That's an interesting question. Yeah, things like earplanes, aqua ears, HBOT, they're designed with a sort of porous filter.
What does filter do?
It slows down how quickly the pressure changes right against your eardrum in the ear canal. It acts like a buffer.
So it gives the Eustachian tube more time.
Exactly. It smooths out the pressure curve, you could say.
Yeah.
They have shown some use for adults who regularly struggle with equalization, like on flights.
Could they be used in HBOT then?
Well, the sources we looked at didn't cite specific controlled trials for HBOT use, but the authors suggested they might be a reasonable thing to try for an adult having chronic issues, perhaps before jumping to surgery.
Any downsides?
The main caution is with kids. Getting a really good seal is crucial for them to work, and that could be tricky with smaller or variable ear canal sizes in children.
Right. Fit is important, so maybe an option for adults, but maybe not the first go-to. Okay, that brings us to the surgical option then, myringotomy. What exactly is that?
A myringotomy is basically making a tiny cut, a small incision or perforation in the eardrum, the tympanic membrane.
And when would you do that?
It's indicated when a patient is in the chamber, they're pressurizing, and they get acute, significant ear pain from barotrauma, that pressure injury. And the other methods, the Toynbee, maybe decongestants, they haven't worked. It's to provide immediate relief.
So it physically lets the pressure equalize.
Precisely. It creates an alternative path for the pressure to balance out.
Are some people more likely to need this? Are there risk factors?
Well, one study did look at factors linked to needing tympanostomy tubes, which are related. It found things like older age, having had radiation to the head-neck area, being on blood thinners, heart disease history, having an active infection, a history of trouble equalizing before, and also female gender seemed associated. But, importantly, the study didn't find enough evidence to say, okay, everyone in this group should get tubes put in beforehand. Prophylactic tubes aren't generally recommended based on those factors alone.
What about someone who's unconscious in the chamber? They can't tell you their ear hurts. Would you do a myringotomy just in case?
Generally, no. The sources suggest it's not needed or advisable if there's no sign of pain from barotrauma. Even if the eardrum were to rupture spontaneously or fluid built up, those things usually resolve on their own.
Okay.
The risk of actual inner ear damage in an unconscious patient from just middle ear pressure seems very low, not enough to justify routinely doing a myringotomy.
Makes sense. Don't intervene unless necessary. So if it is needed, how's it done? Walk us through the technique.
Okay. First things first, you need a clear view. So clean the ear canal if needed, get a good bright light, usually from an otoscope with an operating head. Sometimes a headlight or even a microscope might be
I want
used.
to position the ear.
Yeah, gently pull the outer ear up and back. That helps straighten out the canal for a better line of sight to the eardrum.
What if there's earwax in the way?
Got to get it out. An experienced clinician might use a tiny wax loop, but often a safer way, especially if visibility isn't perfect, is gentle irrigation with warm water.
Irrigation, like squirting water in.
Yes, but carefully. Using a syringe with a special lure lock tip, that's crucial. You attach a soft, flexible plastic catheter to it. The lure lock stops the catheter accidentally shooting off under pressure.
Ah, vital safety feature. Is it safe to irrigate if their ear already hurts from the pressure?
Yes, because the pain itself tells you the eardrum is likely still intact. If it had already burst, the pressure would be equalizing and the pain would probably decrease.
Gotcha. Okay, canal clear, eardrum visible. What's next? Patient positioning.
Usually lying flat, head turned slightly, need to keep them still. For kids, or maybe very anxious adults, a gentle restraint like a papoose board might be used just to ensure safety during the quick procedure.
And the instrument.
The main tool is a myringotomy knife, ideally sharp, disposable, often with an angled blade for better control. If that's not handy, a simple 22 or 25 gauge spinal needle works too. You can angle it carefully.
Do you need to numb the eardrum? Anesthesia?
You know, surprisingly, for this specific situation, emergency relief of acute barititis pain, usually no anesthesia is needed.
Really? Wouldn't it hurt?
The procedure is very quick. The sharp pain of the incision is brief, often less than the pain they're already in, and it's immediately followed by relief as the pressure equalizes. Trying to apply topical numbing cream or inject local anesthetic might actually cause more discomfort beforehand.
Interesting. So speed and precision. Where exactly on the eardrum do you make the cut? Anywhere.
Oh, definitely not anywhere. Location is critical. Think of the eardrum like a clock face, divided into 4 quadrants. The important structures, the little bones of hearing, nerves, are mostly behind the upper part.
So you avoid the top?
Absolutely. You aim for the lower quadrants, preferably the anterior, inferior, the front bottom part. If that's hard to get to, maybe directly inferior or posterior inferior is okay. But stay away from the superior quadrants.
Why? What's the risk up there?
You risk hitting the malleus handle, the incus, the stapes, the oval window where sound enters the inner ear, even the facial nerve. Injury there could cause hearing loss, bleeding, facial weakness. So staying low is key.
Understood. Lower quadrants only. How big does the cut need to be?
If you're just relieving pressure and not putting in a tube, a simple puncture is enough. Just a full thickness poke through the membrane. It usually heals up on its own in a day or 2.
And how deep do you go?
You have to be careful. Remember, the eardrum might be pulled inward by the negative pressure, and it's incredibly thin, like 0.1 millimeters.
Wow, thin.
Yeah. So you don't want to go too deep and hit the bony wall on the other side. It's best to make the entry point a little bit away from the absolute edge of the eardrum, maybe a few millimeters in, to give yourself a margin of safety.
Okay. What if the eardrum looks funny, like it has white patches?
That might be myringosclerosis. It's like scarring or hardening in the eardrum layer from past inflammation. It's generally best to avoid making the incision right through those chalky plaques because they can be tough to cut through cleanly.
Good tip. Okay, so that's the myringotomy for immediate relief. What about those tubes you mentioned, ventilation tubes or pressure equalization tubes? When do they come into play?
Those are more for patients who need multiple HBOT sessions
Mm.
and consistently have trouble equalizing. Think someone getting treated over weeks for, say, a bone infection or a wound that won't heal.
A longer-term solution.
Exactly. Or sometimes they might be considered right at the start for patients who are expected to get widespread swelling, like major burn victims, because that swelling can affect Eustachian tube function.
How are they put in? Is it major surgery?
No, it's usually done right at the bedside. They use topical numbing drops or maybe a small local injection. A tiny incision is made, like a myringotomy, and then a small spool-shaped tube is inserted into the hole.
And can they start HBOT right away?
Yep, pretty much immediately after the tubes are in place. That's a big advantage.
How long do they stay in?
They're designed to work their way out naturally over several months. They just sort of extrude, and usually the eardrum heals up perfectly fine behind them.
What about care afterwards? Do you have to keep water out of the ears?
That's the general advice, yeah. Try to keep the ears dry until the tubes fall out and the holes heal. While studies suggest normal bath water or chlorinated pool water isn't a huge infection risk.
But lake water might be.
Right, natural water sources carry more risk. And even if it's clean water, getting it into the middle ear through the tube can just feel unpleasant. So using soft earplugs for swimming or showering dry ear protection is usually recommended.
Okay, that covers the tubes too. Wow, we've gone through quite a bit here. From just understanding the pressure problem
Right, the Barititis itself.
to the non-surgical tricks like Toynbee.
And then the details of myrotomy and the ventilation tubes.
Yeah, and it's really striking, isn't it, how sensitive our bodies are to pressure and how precise these medical approaches have to be for what seems like, just an ear problem.
Absolutely. The level of anatomical knowledge needed, the surgical skill for a safe myringotomy, thinking about those tiny structures just millimeters away, it really highlights the expertise involved.
It really does. It makes you appreciate the complexity hidden inside us and the clever ways medicine finds to work with it. And on that note, maybe think about other times you feel pressure changes flying, like we said, or going up a mountain, maybe even just taking a really deep breath.
How does your body normally cope? What could throw that balance off?
Yeah, it gives you a new appreciation for those systems working silently to keep us comfortable.
And it makes you wonder, doesn't it? If our bodies are this sensitive to pressure, what other maybe subtle environmental changes might be having physiological effects that we're perhaps only just starting to understand?
That's a fascinating thought to end on. Definitely something to ponder.